All right. We're going to get started here, guys. First of all, thank you so much for coming out. It is, I know it's late, and I know you're weary, and I won't continue. But I guessed that 7 people would show up to this, and I lose. So thank you so much for being here. I know it's after happy hours and before dinner, and we really appreciate you guys coming. But this is an important topic, and the more folks we have discussing it, the better it is. We really have an esteemed panel here of our staff, and I'm so proud to have them. You can tell it is late, and we've been going since early, so we're going to have a good time with this. But it's a serious topic. My job is to tee this up, and then really, as opposed to most other things, I'm going to get off the stage, or at least sit down, and then have a conversation. We want to get to a Q&A as soon as possible. So we're all going to go through our various topics, but really what this is for is to have an interactive discussion. We have, in addition to Lori, who was most recently sort of on our board, and Lori Bishop is now our Vice President of Palliative Care, was at Sutter, helping lead their advanced illness management program. So well qualified to discuss this topic. Zinnia Harrison, until fairly recently also was at CMS at the Innovation Center, where she was, after having been in the hospice part of CMS, so well qualified as our Vice President of Innovation. Sharon Pierce, who has been our Vice President of Public Policy for a few years. Before that was at the National PACE Association, so really understands this issue from a variety of different perspectives. And Judy Lund-Person, who has been with NHPCO, as you guys know, for a long time, and manages as Vice President of Regulatory Affairs, manages our regulatory area. I am Ido Banik, and together we're really going to try to tackle and do justice to this topic, which is serious illness care. We have recently had a lot of discussions, along with the Academy and CTAC and other folks, about what it means to provide serious illness care within Medicare. We know what hospice is, or at least we think we do, but there's far less definition around terms like palliative care, and as we learned recently, comfort care, let alone serious illness care, or anything else that's out there. We're going to try to decipher and untangle all of these terms and really talk in as practical a way as possible about what we mean when we talk about serious illness care, and then just as importantly, how we can make sure that folks get the right care at the right time. And we can really focus on this issue, not and we've had a wonderful series of discussions today. We're not talking about widgets here, and we're not talking about anything other than how you can get good care to people at the most appropriate time. Oftentimes we lose sight of this as we are in our silos, and some of us live in palliative care silos, and some of us live in home care silos, and some of us are in hospice care silos. But we've really been clear around this discussion that our goal is not to create another silo, not to create something else that serves to further confuse people who are already confused and dissatisfied with the healthcare system, but really make sure that we can add and improve the healthcare system. With that, I'm going to sit down. We're going to talk about various things, and then we're going to have plenty of time, at least a half an hour, for Q&A, which I think would be wonderful. Okay? And we promise to end at 8 o'clock so you guys can move on with the rest of your evening and enjoy it. Thank you. Lori.
All right. Thank you. Thanks, everyone, for coming. And I loved all the talk about silos because I'm from Iowa. So, ba-bum-bum. I think part of this was to give you the opportunity to hear things that are hot off the press, and also to get your feedback. We want to hear what your concerns are about this topic, as well as hear from you about what we can do to support you in this topic, and that's really important to us. Recently, the PTAC, which is the Physician Technical Advisory Committee, which actually there's a few more words in there than that, but essentially that's what it is, had a meeting. How many of you are aware of that? Okay, Good. So see, this is fresh information for some of you. So they're looking at alternative payment models. And they had presentations from both AHPM on a model that was, let me get it right, patient and caregiver support and serious illness model. And then they had a model from CTAC, which was an advanced care model. And that advisory board recommended limited scale testing of a model. So they're presenting that to Health and Human Services to say, yes, we should pursue this. So we wanted you to be aware of that opportunity is coming and could come as early as the end of 2018, or it could be in 2019, we don't know. We also know that the PTAC recommended that those two models collaborate and consolidate. And so that they have been working on that. Zinnia will get into more detail about the specifics of how NHPCO has been involved in that and some more detail about what's happened in that realm, but wanted you to be aware of that model. You'll see the slide that kind of gives you a definition, a conceptual definition of serious illness care. And we wanted to make sure that you think about that serious illness care definition if you're interested in providing this service. Now, another question, how many of you are already providing palliative care to a seriously ill population? Okay. Does this definition resonate with the care you're providing today? Okay. Oh, good. I see some nodding heads. This definition was vetted through some research by Amy Kelly and others. And you can see that it even takes the seriously ill population and ratchets it down. So that C level has multiple conditions, and they have changes in functional status, and they have increased utilization. So you've got multiple chronic conditions, changes in function, decreased function, and increased utilization. And that's your highest risk group. It's important for you to think about that so you know which population you should really be targeting. I'm not saying that's the only population you should take care of, but that is the population where we can do the most good in terms of the value of what we provide and show a difference. Because we know that in community-based care, if we take care of those individuals that are out there in the community and do it out in their home or wherever their home is, that we can impact their utilization of the emergency room in the hospital. And you have several programs across the country that are proving that every day. The other thing I wanted to make you aware of is the opportunity also exists out there already today with commercial payers, especially in the managed care space. How many of you that are providing palliative care are already engaged in contracts with payers? Yay, so a few, that's good. So you know the opportunity out there. The same with accountable care organizations, Medicare shared savings programs. There's a lot of opportunity out there. If you haven't started and you're interested in starting, I guess I want to create a sense of urgency in you and say, get going. And want you to know that we are here to help you get that done. Now, I'm going to turn it over to Zinnia to get into more detail about that.
Hi, everybody. Really glad to see there's more than 7 people, Ito. Just saying. And it's really good to see from the audience the different experience that people have out there. So for those that have been just really focused only on hospice and thinking, I don't know, this might be a fad. Maybe this is just something that, I have to spend resources on and nothing will happen. So let me just kind of flash back to 2014 when Dying in America was published by the Institute of Medicine. And so that volume, if you haven't read it, it's rather voluminous, but it does touch on many aspects of care that you guys are all doing on a daily basis. And it really drills down into some technical details that are really important with a diverse group of people, academic, providers, stakeholders, to really help them think through all these complex issues. So if you think about it, in 2014, it took a while for them to get to even publish that book, right? Following that, there were other activities that were going on. So little things were happening all around, and if you have not been paying attention, I'm going to help you kind of think through, like, wow, that did happen. In January of 2017, the chronic care management codes were allowed to be coded. This is brand new. It was the first time CMS would allow codes to be coded for advanced care planning and chronic care management that really identified the need to have, not just for hospice patients, for those that are seriously ill that could benefit. But it's such a tiny step, but it is a step in the right direction. It's government. They're going to move slow. They're going to want to look at the data. Following that, the National Academy of Science, Engineering, and Medicine also pulled together a roundtable. This is all, all culminating, and they're looking at quality care for serious illness population. They have a series of workshops. Again, they're pulling in experts from all over the country with diverse backgrounds. And that's where I think it's really important to kind of keep abreast of, like, wow, there really is interest. So is it a fad? Probably not. No one's investing money into holding these types of meetings in order to do that. And then, of course, with the PTAC that Lori was mentioning, what was really exciting is to see these two models around serious illness be launched for consideration. And of course, when the committee looked at these two, they said, there's some really solid things about both of these, but there's also some concerns about both of these models. And I think that's a really important moment to just think about, because in your work every day, it's not easy. It's not a simple answer. They might look identical on paper, but what you do for that patient is going to be very unique. It's case by case. So no one does really have that magic bullet. So with CMS at the Innovation Center, while I was there, we were just reading all the things that were public, looking at the models, just seeing what was happening. And CMS is now thinking about developing their own serious illness model. So they're going to take those two models, think about it. They've reached out to various organizations to ask some very specific questions about how do you measure this? How can we make it budget neutral? How do you improve quality, and are you improving access? And those 3 points are required in the statute that allows CMS to test these models and develop these models. So it's not because they don't want to do it, there are a few hurdles that they have to go through. And that's just one step. It is unusual, and I think this is the first time the Innovation Center has ever really gone outside and asked for input and expertise from the community, all of us here. And since they've done that, they will now be going into development mode. And we're hoping at the end of the year that something will be launched. We don't know if it's going to include hospices, palliative care organizations. It could be a hospital system. But what's important is you don't wait until those proposals go out to then apply. This is the time to start networking your community, know your environment, who's out there that would be interested in partnering. If it is a particular physician group practice, know who's in your community so that you can bridge that and say, if there is going to be something, I'd like to be part of that. I could be the one that does that type of care. Really market yourselves, because you only will have 30 days or 60 days to submit a proposal for consideration. And I think that's pretty much where we are today. There's a lot of other activity going on that I'm going to ask Sharon to talk about on the Hill.
Sorry about that. Thank you. So what's interesting from my perspective is that while the Hill is very supportive of this, they're really taking more of a hands-off approach because the administration has been forward thinking on this, and that they've expressed some interest in this, that they've put together the PTAC. So what we've been trying to do is leverage the support that hospice and palliative care enjoys on Capitol Hill to encourage CMS to take certain actions. And so we had a couple of policymakers who weighed in with CMS about, I guess it was probably early February, encouraging them to partake of this model and really weighing heavily on some of the specific proposals that we find most important, like advanced care planning, that be worked into the model, that we have some kind of scalability, but really most importantly is a quality measurement, that that these plans don't just operate in a vacuum, but that we measure the quality of care that they're providing, and included within that is referral to hospice. We do not want these care models to supplant hospice. We want them to complement and create that continuum. And so, our friends and allies on Capitol Hill have been engaged at that level, and they have, continued to introduce legislation. They have weighed in during hearings and asking Secretary Azar and Administrator Verma about these proposals. So I think they're continuing to pressure CMS in this direction, but really letting the process that the PTAC process was created in law to unfold. And so the good news is that I think that our members of Congress who are friendly to our causes are engaged, and they want to be helpful, and that we've seen that through the process there, I think there's been a certain openness and transparency to it that has been really helpful for us to be able to, have that influence, have that shape. Now, we can't guarantee an outcome, but I think that we've really been very well positioned to have the kind of influence for our community, so that hospice and palliative care providers are well positioned on all this stuff. So, it's been a really interesting exercise. It's not just kind of top down, but it's really working it from all angles. And we hope that it will result in a better product in the end, and one that benefits us all.
So I want to go a different place for just a moment, and I want to look around the room for all the people who were around in 1980, doing hospice in 1980. Anybody? Okay. So I want you to remember that in 1980, the hospice that I was a volunteer for had one employee. And that employee was paid because the hospice raised the funds through fundraising events. Everybody else was a volunteer. And I want you to remember, or I'm going to share with you and other people in this room who were there when I was there, remember how incredibly exciting it was to start the beginning, to be there at the beginning of a movement. And I also want to think about our colleagues who were part of the demonstration program, the demonstration project. So this is a history class, and so I want you to tell me how many hospices were in the demonstration. Does any of you can't respond? 5? No. No. 20, how many? 22, no, but you're getting closer. 26. There are 26 hospices around this country who are part of the demonstration project who tested out how hospice was going to be in the end added to Medicare. So we're at that place again, and we're at that place not really knowing like where this is all going to lead, but knowing that we've got patients who really, really need services that are seriously ill. How are we going to do that? We don't know all the ins and outs of that, but we have all of a sudden now we're starting to get a lot more interest and a lot more excitement around what can we do together. So I have a couple of things, and one of them is, please, I beg you, get out of the hospice box. Get out of the box that says the only kind of payment I know is a per diem payment. Get out of the box that says, I have all these regulations, believe me, I know them. I have all these regulations that I have to adhere to. I can't possibly do something different. And I want you, when you get to that place in your head, when you're back home, I want you to remember those 26 hospices who were part of the demonstration project. They didn't know what was going on and what would happen. But look where we are today with that. The other thing I would say is we have almost, they told me just a few minutes ago that the 4th edition of the National Consensus Project Clinical Practice Guidelines for Quality Palliative Care focused on community-based palliative care will be ready for boards, the various boards review next week. An incredible opportunity, yes, incredible opportunity for us to use that as another guiding light for us, so that when we are thinking about how are we going to do this palliative care, we'll have that as one of our guides. And then finally, and Lori, you may want to call on them, for all the folks who are now part of the NHPCO Palliative Care Advisory Council. So, I know some of you are here.
Council members, stand up for a minute. You know who you are. Please stand up. Thank you.
So they will be very active in helping all of us figure out what resources are needed. So I want you to keep going back there in your mind to what was it like when there wasn't much paid employment for hospice professionals, but all the people that worked for hospice and believed in this were volunteers. And I know there are many of you in this room that started out in that way. So this is another incredibly wonderful opportunity for you to be part of history.
Yeah, so yeah.
Because we're innovative.
We're innovative. So apparently, where are the cube mics? They're bringing them down. Okay, so these are called cube mics, and apparently, do you throw them? Yeah. Yeah. So you throw these mics, all right. So when and actually, what we can start, you speak into this part of the mic. So that's what we're going to do. We've got one over there that Steve is holding up. We've got one that I'm holding up here.
Could you all sign a waiver?
They're soft. So that's how we're going to do it. This is fun. It's 7 o'clock on a Sunday night. So talk. You know what? There's nothing more fun than that. We have an esteemed panel here. We want to have a conversation that's sort of a back and forth conversation. And why don't we just, put your hands up if you have a question or a comment, and either Emil or Steve will throw you a mic.
We have one already.
No, you have to throw it. Please, and if you don't mind, stand up and introduce yourself, just so everyone knows who you are.
This makes you feel very awkward, just so you know. This feels very I'm Robin Stavash. I am the Director of Innovation and Advocacy at Care First in upstate New York. And my question is, for a small, medium-sized hospice, is this something that a hospice our size will have access to? Are we only looking at bigger systems and those with a lot of resources as fertile ground for this kind of work?
That's a great question. And I'm one of those folks, as I mentioned, I'm from Iowa, so I've been involved in a smaller program as well as large health systems. And I think absolutely they are going to want to make something that's available to all size of providers. And we also want to make sure it's accessible to rural communities as well as urban and suburban communities. So yes, there will be opportunity in that space for smaller providers. And part of our job with the Palliative Care Council is to create some work groups that will start working on some toolkits to help all size of providers and how they might implement and sustain a program.
How about this side?
Yeah, and let me just add something. I mean, even if we're obviously talking about a demo here, and we're assuming that there's going to be a demo, even if there isn't a demo,
right.
There will likely be Medicare Advantage,
Yep.
ACO, other folks who say, you know what, whatever state you're in, look, we're in the business of providing serious illness care. At a certain evolution of the life cycle, usually the way it works is, you know what, we actually don't know what we're doing. Can you do this for us? And so that's coming, or it's here.
It's here.
And I think then you have to determine exactly how are we going to share risk, what metrics are we going to put into place, and how are we going to provide this care. Demo or not,
Yep.
Our goal is for as many of you to be providing the serious illness care as possible, simply because it's better for the population than to receive the serious illness care from a hospital or from, frankly, anyone else.
And actually, did any of you in this room go to the palliative care pre-con? Oh, I thought I saw some of my friends in here. So you heard, right, that the opportunity is now with those payers, and that those payers are looking for programs to partner with. And they're having a hard time finding the programs. So your opportunity is absolutely now, regardless of the payment model.
Who's next? Okay. Here we go.
Aw, yeah, woo!
Nicely done. I'm Joan Harold with Hospice Community Care in Pennsylvania. How will the information out of MCCM, the Medicare Care Choices model, be?
Down, Joan, thank you.
Oh, well, you're welcome, Sharon. I'm glad I could help. Because I realize this does not have a prognostic threshold, and MCCM does, but nevertheless, we're still doing upstream palliative care. So how does that, the results from that, or even just what it has taken to do that, feed into this? You want it back?
Ooh, good arm.
And I have to say, by the way, I was on the selection panel for MCCM. Xenia used to run MCCM, so Judy will talk about MCCM.
So Zinnia wanted me to tell you that.
Throw your votes.
Yeah. You got it? There you go.
So Zinnia wanted me to tell you that she doesn't look good in stripes, so. But I think MCCM is far enough along. We have a couple of years of data with the first cohort, and the second one started in January. So certainly there is some learning. I think one of the things that will be a big difference with this is that there won't be a must-be hospice eligible component to it. And I think there are some things that will be good learning. There are some experiences with providing wraparound services that for a modest price that will really, I think, be very instructive to other providers, other hospices as we move along. But there are also some limitations because of that hospice eligibility criteria. Any of you who are in the model have other thoughts on it?
You'll be precluded from participating in both. If you're participating in the demonstration project, can you also participate in this?
We don't know.
We don't know.
There's no this, yet. But
Yes.
so it's uncertain. I think that one thing to keep in mind about MCCM, I could say this. There's obviously a lot of focus on MCCM as an end in and of itself. Limitations with MCCM and the like, and that's definitely true. But that's not the end. The end is if Medicare provides concurrent care, if Medicare provides both curative and palliative care at the same time, does quality go up and down, does cost go up and down, and that's what's being tested. That's going to obviously be very informative to CMS in putting this demo together, or any other demo. Yes.
Hi. So I'm Lauren Island, and I'm from Metropolitan Jewish Health Systems in New York City. And we have a very large managed long-term care plan that has very many Medicare fee-for-service beneficiaries. And so I think a larger question that I have when I hear this is that while this is a great opportunity for us in terms of for our hospice, the models that I read, there's it sounds very similar in that you're going to have a per member per month care management fee. And so what I think is important for the demo, because we want this to go well, is how do you prevent the death by care management? Because depending upon the state that you're in, a lot of people may have a serious illness or be getting, like, let's say, personal care services. And just, how can everybody play nicely in the sandbox and coordinate different things? Because it could work out very well. And we do have situations where, someone could be in two different plans, right? You have a Medicare Advantage plan, and then you have a managed long-term care plan. So it's not like there's not a precedent. But I think depending upon the market that you're looking to do this in, and we really are interested in doing this in a New York market, we just want to make sure that there's some fleshing out of those kind of questions and concerns. Because when I read the proposal, it all seems that it's kind of like your 35,000-foot view, right? It looks very, very nice. But then when you go to the individual state levels, you just come into these other complications.
So thanks, Laura. It's interesting that you raised those exact points because those are similar points that the PTAC was concerned about. And, which is why they cannot recommend just implementing one. That's one of the options they can do, right? They could just recommend implementation to the secretary. And they didn't do that. I don't know what's going to come out of that, but based on the discussion, it sounded like they recognize that this is a very important model to design. And then it was open because there's a lot of issues that they're concerned about, and they want, and I think CMS is in the same place, which is, how do you handle those that are already in a managed care state or heavily managed care? What about that? And also having a diverse enough pool of participants that they can then generalize the findings at some point in the end, which speaks to the small providers. I think that is very important because they recognize that many hospices, although not as many as before, when Judy was talking about, there are a lot of mom and pops and small hospices that are still out there and operating. So they want to be able to test this in such a way that, what is it going to tell us in the end?
So don't just think of the care management.
Right.
Also
Right.
think about whatever benefit packages that's going to come with it. And what I mean by that is, like, is this going to have DME? Is this going to have personal care? Okay,
I
because
have asked all those questions.
right,
Yep.
people need that and
Yep.
to stay safe. But just having some of those guidelines, because I would also recommend, there is a request, right, for information right now for stakeholder input that the DSNP plans just had to submit. And I can tell you from being a part of those conversations that all of these state differences absolutely came up.
Yeah.
And I don't think that, the Medicare fee-for-service, you're going to find that too, right? So that might be a good collaboration from a policy perspective, because what would be good for like the MA side would be good potentially for fee-for-service.
Right.
And it just may make it easier in the providers in the long run to engage.
Yeah, I think that one of the things that I was going to say is that I think with each iteration, whether it's MCCM or the PTAC model, I don't know that I look at these and see, okay, we're now in the stages of creating a forever new benefit under Medicare fee-for-service, because I think that what we're seeing is Medicare fee-for-service is a smaller and smaller portion of beneficiaries. And I think, and Zinnia can correct me if I'm wrong, I think the way the MCCM was constructed, you couldn't be in an MA plan and in a MCCM plan. So they excluded some of those participants so that we were focusing exclusively on fee-for-service. But I think one of the benefits of MCCM, even with its problems and with its challenges, is that it informed the development of that care model and the pricing of that care model, so that you can now go back to plans and say, okay, I can provide these four corners of services with some specificity as it relates to DME and personal care services and the like, some limitations on that, but then also demonstrate the value. And I think that that's something that we all kind of still struggle with. And as Ito references, there's still so much variability in what constitutes palliative care that you can't, you're comparing apples to oranges, because A, there's variables in state, from state to state, and then from community to community, and then based on the provider. So we're trying to create some uniformity of what you can expect when, as a payer, as a provider, as a patient, this is what I'm going to get when I get serious illness care. This is what I'm not going to get, and trying to answer some of those questions. And it's complicated. It's hard to answer, but I think that that clarity is important. We're trying to create regulatory frameworks that fit together and that don't get in each other's way. And it's a struggle, but I think that we're asking a lot of those questions, and we know to ask a lot of those questions, but that's why we need to hear from you, because we sometimes stumble upon things that we didn't think about. And so that's why, it's thrilling to see this many people engaged in the palliative care committee, gives us some of those feedback loops. So keep them coming.
It's really well said. If I might just add, I think that it would be tragic, and I said this earlier today, if what we did when we created a serious illness model was sort of exacerbated the problem that we see now, which is you've got various buckets, folks are confused, we're going to add another bucket and confuse folks even more. No, I'd rather not do anything. So it's really important to think about how what we're adding actually simplifies people's lives and gives them earlier access to care, and to Laura's point, makes it something tangible. And there's enough sort of amorphous stuff out there that isn't well defined that confuses people enough. And I would add, New York may not be the best place to do this kind of thing, because you've already got, your disrupt, you've already got the MAs, you've already got the FIDA thing, you've already got various things going on at the same time. Yeah, but not every state's like New York. And there are some states that doesn't have the same density of all the things going on at the same time that may be better candidates for doing this kind of thing. More questions?
Okay, here we go.
Nice, I love
Oh,
this.
very nice form.
Hi, Mark Cohen. I'm the publisher of Hospice News Today.
Good to see you.
Thanks. So I come at things as a communicator. So where in the process and when in the process of filling in the blanks are people going to focus on the issue of convincing consumers that getting serious illness care from a hospice provider is not in fact an immediate death sentence, particularly in talking to underserved communities that don't trust the system anyway and have issues with hospice in that regard as well?
Well, one answer is come to tomorrow morning's plenary, because that's what I'm going to talk about. I don't want to scoop myself, but we are launching a campaign to do exactly that, to make sure that we establish community-based hospice and palliative care providers as really the base that is in position to provide this kind of care, and make it so that folks are a lot more comfortable choosing that option a lot earlier. Part of that has to do with messaging and communication. Part of it also has to do with the benefit itself. Yeah. It is not helpful that you can't get concurrent care. It is not helpful that you have the 6-month limitation. And those are things we're going to have to work on as well. Nice.
Hi, I'm Barb Hansen. I'm with the State Associations for Hospice and Palliative Care in Oregon and Washington. And Judy, going back to your history lesson, so I can remember in the mid-'80s and late '80s, hospice programs debating whether they wanted to become Medicare certified because they didn't want to taint themselves with the filthy lucre. So I had been an intensive care nurse and then a home health nurse, and then we started working with this all-volunteer hospice. And I remember having to try to explain to a patient and his family what hospice was going to provide that home health wasn't already providing. So the reason I'm mentioning this is because it's not just the consumers who need to understand what's provided, in the toolkit. You need something for the staff, so they and the intake people, so they can clearly say, yes, with this benefit you get this, and you have this copay or whatever. Because staff get confused too. I mean, there's a lot of hospice staff who don't understand what palliative care is, frankly. So, and I remember feeling that way in the '80s.
That's a great point, and I can tell you the programs that do this well today that already exist, the staff has to be competent in home health care and hospice so that we get people connected to the right service at the right time. And then it shifts the conversation to what are your care needs and which of these programs would best meet your need. And so actually, that's changing the conversation even to get to hospice. If, I start to see that you need this, this, and this, we're already starting to have those conversations, right? So then when that comes up, we say, remember how we talked about this, this, and this? Now you need that. Now it's time to go here because that's where you're going to get that. And so I think it's really important I don't think it hurts to emphasize this again. This is not to replace hospice care. It's to fill a gap that exists in care today. It's not to replace home health care. That also fulfills, we don't want to replace that. but we want to leverage each of these things and certainly other things within the community to connect people to services in a timely manner. So we got to think longitudinal. Thank you.
Yes, you can.
You're right.
Okay, maybe you can't.
I grew up as a dancer, not a baseball player. Oh. Sally Aldrich, Memphis, Tennessee. I just have a quick question. We've had good success with our concurrent care for children in our pediatric program. Is there any elements from that that is replicable in the adult side?
That's a great question.
Even though I can't catch them, and you throw it.
You notice she's saying, I don't want to answer that, can you? I think one of the hopes with the concurrent care for children demo and model now all together is that we would learn how that works and how we might use that in the adult population as well. I think there's some good learning. I think we've had some politics get into it in the way of some of it in some states, and the volume is really small. That's the other piece of it. So I think, you know, if I were channeling Zinnia and all of our colleagues at CMS, they would say, well, we have to make sure it's budget neutral. Well, no way is it going to be budget neutral. So I think definitely yes, there's some learning. I think there are some other challenges just volume-wise that we'd have to take into account.
So, my concern with a new model, there are a few. One is we need to have rigorous standards by which eligibility criteria.
Yes.
I'm really concerned that we'll dilute the notion of serious illness care by not creating eligibility criteria. I actually believe in the eligibility criteria of the hospice Medicare benefit. I don't believe in the 6-month time frame.
Mm-hmm.
The clinical criteria are reasonable. The 6-month prognosis is not.
Well said.
When we look at developing serious illness care criteria, we need to use the same amount of rigor. We need to use evidence-based science that says, would you expect this person to die within X? It could be 2 years. It could be 3 years. You could have a serious illness patient who has a neurodegenerative disease like ALS, who could live 5, 6, 8 years. Is that the population that we want in here, that you want in the model, or not? So I'm just asking the group of experts to engage people throughout the country who have experience in this and get our input into the population that we're seeking. We want the most seriously ill who are on a trajectory towards end of life at some point. Otherwise, you're going to open up a big mess.
Yep.
Okay?
Here's what I would say, though, and I agree with those comments. What I would say in return, though, is that we're talking about fee-for-service land. We've got the status quo, and we're developing an alternative payment model to provide serious illness care earlier than hospice care. But over in managed care land, we've just opened up even further the flexibility of health plans to decide what kind of non-medical supports and services they want to cover. They're already covering bundles of palliative care service that they're paying for, and I think what concerns me is that if we tighten up the serious illness care too much in fee-for-service land, it'll make it even more of a unfair battle between the managed care folks who are already advantaged in some ways and fee-for-service, in the sense that we'll have this very limited serious illness model, and then the managed care companies will be able to develop whatever bundles they want and market those bundles Whether or not those are serious illness bundles is irrelevant. They're flexible enough to provide those, and there's going to be a real asymmetry, and that's going to exacerbate the numbers that we see in fee-for-service versus Medicare Advantage, and is going to make it a real challenge, and ultimately, I think, decrease length of stay even further. That's me. That's, and I'm not the expert so much up here, but that's my concern. You guys have a thought about that?
So in developing eligibility criteria for a model to be tested, this is where reality and research collide. So you know what you're experiencing providing the care. You know who that serious illness patient may be. When I talked to Lori, she's like, I know exactly when that person would be eligible. Now, on paper though, CMS has to be able to compare it to a control group. And they're gonna look at claims data, right? So, and they also are gonna have to struggle with how large is that denominator, how big is that population they can actually test in order to actually have a result to say whether this model is worth implementing permanently or we need to test some more. And so I think that's the struggle that we heard from CMS when we met with them, is they kept kind of asking, well, what exactly would be provided, what Laura's point is, and who exactly are we talking about? Because they're trying to find that group. We don't know where they're going with that, but we gave what we could as far as our thoughts from Lori's experience too.
I tried to pull from y'all's experience too. It wasn't, just so you know.
It's from Sutter.
But what we created vignettes, patient vignettes, just to, and kind of tried to give a variety of patient types to give them kind of a sample. And it took us quite a while to get through. Poor Zinnia, I kept pouring crap at her for a long time until she finally was like, this is what I need. She didn't do it that way. But I think that's, it is. The devil's in those details. And I hadn't really thought about the control group, but I know just any of us that have tried to do research appreciate it's very hard to identify a control group for this population. So.
And there's many other models where the same population may be exactly, the right group to participate in the new model. And so the sample size starts to get a little bit small. And the vignettes that we developed were very diverse.
Yes.
So, we thought about somebody in a rural area. We thought about somebody in an urban area. We thought about somebody that did not speak English and needed that extra layer of translation that's costly. And whether somebody had caregiver, not a caregiver, somebody that, so we did try to create quite a range of what they may experience as they're thinking about how to develop a payment model around it.
So, it's me again.
I mean,
hello.
You have to catch it again if you want
Steve was nice enough to just hand it to me. He's like, shut up, lady. Regarding the research, there are some good evidence-based research articles out there now that demonstrate control groups who've had, specific advanced illness care, serious illness care versus usual care using claims data, Medicare claims data. I can think of two. One would be Dana Ledbester's group, and then Sharp Healthcare, our group, and then AIM, and then Kaiser. And there are some articles out there that demonstrate the efficacy of an intervention, palliative intervention for serious illness management at a certain point in a person's illness. Are you taking those research articles into consideration in your development?
Oh yes, we sent references upon references, right, for CMS to consider. Since we're not the ones developing, we can only provide our thoughts about things that they should be looking at.
And then one follow-up question, and I will get off the stage. Do you have physician leadership involved in helping you with the proposal to CMS?
So CMS also talked to the American Academy. The American
Are you talking to practicing physicians?
Yes.
Or academics?
Both.
Okay.
And I have to recognize Steve Smith from the Academy is here, and certainly you should feel free to chime in. But this has been, this has been
Grab the cube, Steve.
This has been something that CMS has sought input from numerous parties on, and we commend them for that.
Sure. So just briefly, thanks for putting this town hall on. This is definitely the time we want to activate everybody and have everyone have a better understanding of what's been sort of happening behind the scenes. So the Academy started this project about a year and a half ago, but very early on engaged all of our coalition organizations to make sure we had input. There was a core group of physicians that kind of got the ball rolling, that include practicing physicians, academic physicians, researchers, but all along the way it's been a partnership with NHPCO, with CAPC, with HPNA, with the Social Work and Hospice Network, and lots of other groups. Actually, about 30 groups have had input, including some patient advocacy groups. So this is really significant. I mean, we're excited about where we are, but as everybody has talked about, the next part of it is sort of hard for us to influence. We've done a lot of work up front. There's still a lot of conversations happening before things sort of go behind the closed door and the demonstration gets designed and developed. But then it's going to come back out, and it's going to be all of you who, the questions you're bringing up, the concerns that you have, the ideas, the patient and family experiences, that's going to be part of that living laboratory that's going to inform and really redefine the model that gets developed. So that's all to come, but it's not that far away, as you said. So we appreciate your questions and the collaboration that's going to be required to make sure that the demonstration is successful and that we have ample participation is going to be really the next big step.
Yeah, thank you. And,
Sure.
It's been a wonderful collaboration. The thing that I would say, we really tried to hammer home for CMS and for everyone is that this isn't about us. It's not about providers or the industry, physicians. It's about patients and families, people. We want to make sure that folks are getting the right kind of care and that their voice is heard. And if the model that comes out is ultimately not good for people, it's just not something that is going to get a critical enough mass to get off the ground. And I think CMS takes that seriously. They understand that they're trying to put together a model that will be taken up because it has a shot at being a step forward. I see Laura. Anyone else not ask a question yet that wants to? Otherwise, we'll go back to. Yeah. Okay, well, back to Laura then.
Back to Laura then, right?
Going once, twice.
Here we go.
John.
Here we go. Over here.
Hey.
My kids would have really loved seeing me catch this.
She's on video.
Marcia Hassan with the Carolina Center from North End, South Carolina. As you talked about not duplicating what the Medicare benefit is, but I also think about when you mention caregivers, will this sort of demonstration project take into consideration the gaps that are there for caregivers caring for people at home and needing support so they can keep that person at home and not have to take them to the hospital?
It should. We've provided not only that, but also provide bereavement care, and we have certainly provided that feedback.
Yep. There
Joan?
may well be caregiver assessment, caregiver burden assessment or a component of that. I think that's, I think we're appreciating the role of the non-paid caregiver and the necessity of those caregivers and their burden. So I think it will likely include some of that.
So one other thing just to throw into the conversation, and that has to do with the sort of confluence that we're seeing between analyzing data so finely that we're finding things that are making things difficult. I'll come back to what that is in a second. As well as let me start with that, then it'll just be easier. So we know that we've been looking at data by disease groups and have been concerned that, we in the fee-for-service hospice type model, per diem, we're saving money for some diseases and not for others, which then obscures the whole issue of what's good care. Because if this was created to be a health delivery model, it wasn't created to be a health delivery model that was parsed so finely that it only counts as good, affordable care in a tiny slice. It's like telling me to go to the grocery store and save money. I can save it on my whole bill, or I can save it on every single category. And maybe I'm going to save it on my whole bill if you let me spend more in one category than in another. So this issue of we're not saving as much money in Parkinson's, we're not saving as much money in Alzheimer's, we're not saving as much money in neurodegenerative diseases, obscures the fact that it's still good care. So I guess my first point is we can't parse the data so finely that we expect everything to go well and be budget neutral in every teeny tiny category, or else we're missing the fact that it's good care all the way around. Secondly, we're starting to hear medical necessity. We're starting to hear things about, and it depends sort of on your MAC, but medical necessity has always been based on what good care is for the kind of disease and functional status somebody has. It hasn't been, how much do you need us to do for you? So I would also then throw that caution in, that medical necessity needs to be well defined across the board and not based on whether or not somebody needs a particular med or a particular service or a particular caregiver. If we're saying what good care is for serious illness based on conditions and function, and it can't be budget neutral necessarily in every single tiny slice, we've got to have some freedom to deliver good care to people based on what they need and not based on whether or not we're saving money in every single category.
So the requirement for Medicare or the Innovation Center and the law that they are working under is they compare it to total cost of care, right? Like the total cost of payment. So, but my disclaimer is that the Office of the Actuary has to certify that it is budget neutral or saver, which what that ultimately means for those actuaries is that there is a high bar that they have to compute that. It's not necessarily by discrete categories, as you're saying, but they could think about budget neutrality in a different way. Like, is it that, and this is radical, right? It's not just Medicare payment, but what is the burden from the family not having to take time off from work? And, you know, it is thinking about it very differently, but it's not constrained to just necessarily Medicare payments only. It has to be budget neutral, but they're thinking of innovative ways to, what does that mean? So.
Yeah, no, I think, and hopefully they'll be able to, you know, I don't see them parsing it by disease category. I think it's going to be in the aggregate. I did want to say something about medical necessity because I think it's important. The whole concept of medical necessity implies that there's a medical component, and to some of this care there isn't. You know, I go back to what's going on in managed care land, and what's going on in managed care land where health plans have been given the flexibility to provide non-medical supports and services. There's no medical necessity test to determine whether or not Mrs. Smith gets non-emergency medical transportation, home-delivered meals, housing, or anything. And frankly, there's also no standard. The health plan determines whether or not they provide it, full stop. So it's really going to be important to determine what the parity is between what's going on in managed care land and what's going on in fee-for-service land. And there has to be flexibility, not judged by a local medical review policy, but by something a little more loose than that. And there has to be some trust put in you as providers to provide the best care possible within certain constraints that are more flexible than the ones you have now, I think. So we have, I would say, time for one more question.
Okay.
Mark,
Here we go.
You're it.
Go long.
Oh.
Okay, all right.
With regards to the earlier question about rural and ex-urban markets, and with regard to the question about physicians, are nurse practitioners also at the table along with all the different types of physicians?
Absolutely.
Okay.
And
Yeah,
I'd
no, I
say
think
PAs, right?
nurse practitioners and physician assistants as well. And I think we've made some progress, and not enough, but we've made some progress in hospice recently. Let me just say this, and I think, in closing, first of all, this is incredibly helpful, this sort of back and forth discussion. It really helps to inform us. This is not obviously we don't know all the answers. We're better informed, and I think we're smarter for having had this discussion, and this won't be a one-shot deal. At some point, CMS will announce something. We'll likely pull something together through a variety of calls and committees and other things like that. And we'll want to make sure that whatever we do is going to be beneficial for people, will be beneficial, obviously, for our providers. And this is something that's both exciting and terrifying, we realize, but we're only going to support it if it's an opportunity to deliver better care. Any parting words?
I have a couple. Oh, go ahead.
Please.
I'm just going to put in a shameless plug for Coffee Talk tomorrow morning at 7 a.m., which is We Honor Veterans. So look that up on your agenda. Please come. I'd love to see you.
That's so funny because I was going to do a shameless plug as well. Mine is, first of all, we are opening the My NHPCO Palliative Care Community. You could all join that palliative care community and start collaborating within that community anytime you want to. We've already added all of the experts on our Palliative Care Council to that community, so we've started some talk in there. We need to get more going in there, and we really want to hear from you. The other thing you can do if you have any questions, feedback, comments, concerns, is we have an email now that is palliativecare@nhpco.org. palliativecare@nhpco.org. So you can submit any questions, comments, feedback to that email, and we'll get back to you as soon as possible that way. So I hope you're seeing the P is not silent in NHPCO. You could take that so many ways.
That's probably a good way to
I can't really mic drop a lavalier, but you know.
You can mic drop one of those mics.
No, I was just going to say, and even beyond that, and there are a lot of these folks already in the room, join our committees. Like, this is the formal structure that we have for feedback. Obviously, pick up the phone and call us anytime, email Lori. But, that's how we engage and how we have those conversations. So the Public Policy Committee, the Regulatory Committee, the Quality and Standards Committee, the new Palliative Care Advisory Council, otherwise we're just making it up. So we need your input. We want your input. We crave it. And we have all these different ways for you to provide it. So just stay involved in the conversation, and we will try our best to share with you what our thinking is and to have that dialogue, because we can't always be in the same room together. So just look, I think the NCHIP section is, or my NHPCO section is a really good way. So join us.
So, and finally, not just join the committees at the NHPCO level, but also pay attention to what's going on in your state. And if there are activities around palliative care at your state hospice organization, absolutely get involved with that, because as Laura was saying earlier, there is a lot of activity around this issue at the state level and some state nuances that I think are also really important. So, and just remember, this is a new opportunity to be a pioneer.
Thank you, guys.